My name is Eric Heyman. I'm at the University of South Florida, and I'll be discussing complication avoidance in spine surgery. Complications represent an unavoidable part of spine surgery. No matter how careful the surgeon, no matter how appropriate the patient, all spine surgical procedures have an associated complication rate. These can be quite low, on the order of a few percentage points for simple procedures such as laminectomies and microdiscectomies, to quite high. A deformity procedure such as a 3-column osteotomy carries an overall complication rate of about 70%, meaning the majority of patients will receive some form of often major complication when they undergo this procedure. More importantly, all spine surgeons have complications, and in many ways the hallmark of a good surgeon is not a lack of complications, but appropriate recognition and management of complications. Complication avoidance takes place in 3 phases. The first is preoperatively. Patients, when possible, should be screened for modifiable and non-modifiable risk factors. In the event a modifiable risk factor is identified, efforts must be made to correct it, if possible, prior to surgery. For non-modifiable risk factors, the complications associated with these risk factors must be identified, and efforts must be taken to both screen for these complications and reduce their impact should they happen. Intraoperatively, safe, careful technique represents the hallmark of complication avoidance. However, a variety of adjuvants have been proposed to prevent certain complications, and their inclusion in the surgery is worthwhile as a method to avoid complications. Finally, postoperatively, there are some management choices that can affect the rates and impact of certain complications. Broadly, we'll be discussing several different types of complications. Infection is obviously a part of any surgery where hardware is going to the body, and this is especially true for spine surgery. Other complications that are relatively unique to spine surgery are vision loss and neurologic injury, both peripheral nerve and spinal cord. Thromboembolism is a common part of any surgery. Unfortunately, however, spine surgical procedures, due to the need to avoid anticoagulation in the immediate postoperative setting, place patients at higher than normal risk of these complications. Finally, a number of specific approaches in spine surgery have very specific complications, and their discussion is warranted in a separate section. In many ways, infection represents the classical complication of spine surgery, and in many ways it embodies the concept of preoperative complication prevention. Although certain risk factors for infection, such as immunosuppression, pre-existing spine infection, etc., are unavoidable, there are a number of modifiable risk factors. Perhaps the most important is diabetes. Patients with uncontrolled diabetes have a significantly high risk of wound infection and other complications. Ideally, these patients should have their glycemic control improved to an A1C of less than 7.5 prior to surgery. On the opposite end of the spectrum, malnourishment is a common problem in spine patients, particularly elderly. Malnourishment is ultimately a clinical diagnosis. However, adjuvants such as prealbumin and albumin can help confirm the diagnosis of malnourishment once clinically suspected. If possible, nutritional rehabilitation may reduce the effects of malnourishment with regard to infection, and which should strongly be considered for more elective spine surgery. Finally, MRSA screening can represent an important aspect of infection prevention because decolonization protocols may reduce the infection rates from MRSA. Intraoperatively, sterile technique has remained the hallmark of infection prevention and surgery from a general perspective since the 19th century. Although some studies suggest that loss of sterility is unavoidable, there are nevertheless steps that can be taken to maintain a sterile environment, such as minimizing personnel changes in OR traffic and changing gloves throughout surgery. Antibiotics obviously represent another important part of intraoperative infection control. The key here is that the antibiotics must be appropriate. If a patient has MRSA, a penicillin-based antibiotic regimen will obviously be ineffective. They also must be given in a timely fashion within 1 hour before surgery. Although topical antibiotics have remained popular, the idea being to give a focal dose of antibiotics to overcome any sort of inhibition on the bacteria to systemic antibiotics, the evidence supporting them is less clear, and the jury remains out on their utility in terms of infection prevention. Regarding postoperative antibiotics, although surgeons frequently will continue antibiotics for an extended period of time after surgery, anywhere from 24 hours to the duration of drain placement, there's less evidence to support this, and there cannot be as strongly recommended as perioperative antibiotics. Finally, drain use may reduce infection by preventing dead space and assisting with wound healing, although, again, strong evidence is lacking in this regard. Venous thromboembolism represents a primarily postoperative issue affected by postoperative management. The keys to preventing venous thromboembolism represent early mobilization, ideally the day of surgery or as soon as feasibly possible afterwards, early initiation of mechanical prophylaxis, and finally, early chemical prophylaxis. This latter point represents an area of controversy in spine surgery due to the fear on the surgeon's part of epidural hematomas. However, within the limitations of available evidence, early chemical prophylaxis, 24 hours after surgery, does appear to be relatively safe, with the risks of thromboembolism outweighing the risks of epidural hematoma. Vision loss is a rare but especially feared complication of spine surgery. It's thought to be due to an ischemic optic neuropathy due to a combination of facial congestion, pressure on the eyes, and blood loss. Although rare, it tends to accompany prone higher blood loss surgeries. Avoiding vision loss really depends on intraoperative type prevention. This includes careful patting of the face to avoid eye pressure and strong consideration to Mayfield or Gardner-Welltong fixations for certain patients who are thought to be at high risk for vision loss, such as those undergoing prone high blood loss long duration surgeries. Similarly, during these surgeries, if excess blood loss occurs or the surgery duration is going significantly longer than anticipated, it may be more appropriate to temporarily abort the surgery, close the patient, allow them to recover, and complete the surgery at a later stage. Finally, care must be taken to avoid positioning the head below the heart if feasible to allow for venous drainage and prevent damage to the retinas. Spinal cord injury obviously represents the most feared complication of spine surgery. Aside from careful, gentle technique, other measures may reduce the risk of spinal cord injury. These include maintaining appropriate arterial pressure. This is especially important for patients with an at-risk cord, such as those with severe pre-existing compression. Intraoperative neuromonitoring also has a role in preventing spinal cord injuries, especially for complex cases, as it can allow for identification of any intraoperative maneuvers that are compromising cord function and allow for their correction prior to permanent spinal cord injury. Finally, for patients with unstable spines, appropriate stabilization must be maintained during intubation and positioning. This can synergize with intraoperative neuromonitoring as changes in signals can help uncover changes in spinal alignment with positioning. There are finally a number of approach-specific complications which are worth separate discussions. Anterior cervical surgery represents one of the most common approaches to the cervical spine. Dysphagia represents an extremely common complication of anterior cervical surgery. Its etiology is thought to be multifactorial due to a combination of nerve injury, esophageal swelling, and retropharyngeal space swelling. Although all patients do experience dysphagia to some relatively small degree, in some cases it can be severe enough to compromise the ability to swallow. One of the keys for preventing dysphagia is to minimize retraction and minimize retraction time, with consideration given towards intermittent relaxation of the retractors to allow perfusion. The role for steroids, either topical or systemic, is less well defined, but there does appear to be evidence that steroids, especially when given systemically, can reduce the effects of swelling on dysphagia without compromising fusion. Dysphonia is another complication of anterior cervical surgery due to a combination of stretch and direct injury to the laryngeal nerves. Although side of approach may minimize the risk of recurrent laryngeal nerve injury, as it appears to be anatomically better protected on the left side, this is by no means certain, with some authors advocating that either side is acceptable from a dysphonia perspective. Finally, one complication worth discussing is esophageal injury. This is an uncommon complication, but potentially devastating, life-threatening complication of anterior cervical surgery. Although certain maneuvers, such as placing an oropharyngeal tube, can help with identification of the esophagus, one factor which should be identified is the patient's surgical history. In any patients with a complex history of, for instance, neck surgery, should be considered for evaluation by ENT for assistance during exposure. In the event an esophageal injury does occur, the key is early recognition. If an esophageal injury does occur prior to discectomy, strong consideration should be given to avoiding the surgery prior to the placement of hardware or disruption of the stability of the spine. Other services should be brought in for evaluation, such as ENT, and strong consideration should be given to a flap-based closure using a local muscle flap. Anterior and lateral lumbar surgery also carry their own specific complications. Vascular injury is obviously the most feared, as it can be immediately and very quickly life-threatening. As such, vascular surgery, or a surgeon capable of handling a vascular injury, should be immediately available whenever these types of surgeries are performed, and plans made for transfusion and or blood recycling due to the possible and catastrophic nature of these injuries. With regard to anterior surgery, one other complication worth discussing is retrograde ejaculation. This can be devastating, especially to young men. The complication at minimum should be discussed at length with them, and appropriate measures taken to mitigate its impact, such as preoperative sperm banking. BMP has been linked to retrograde ejaculation, and in patients who are at risk for it, due consideration should be given to avoiding BMP use if possible. With lateral surgery, the lumbosacral plexus is obviously at risk especially at the L4-5 level where the femoral nerve courses extremely closely to where the retractors and the cage will be placed. Important risk factors to reduce femoral nerve palsy include minimizing retractor side, careful study of the preoperative anatomy to identify unfavorable psoas architecture, and in the event that acceptable distance between the retractor and the femoral nerve is not achievable, strong consideration should be made to aborting the surgery and proceeding via a posterior approach rather than compromising femoral nerve function. To summarize, complications are an unavoidable part of spine surgery. However, specific measures can be taken both preoperatively, intraoperatively, and postoperatively to reduce both their impacts and rates. Thank you very much.